Thank y'all for joining us, and thanks for that introduction and hosting me tonight, guys. So yeah, I'm Jacob Ark. I'm a urologist at Urology of St. Louis. Although I do practice general urology based on my training, we did a lot of prostate cancer, both localized and advanced disease at Vanderbilt. So when I came to the area, I started taking over a lot of the localized and advanced disease space out here. So let's talk today. Let me get our slides going here. That's just some of my background. Again, they talked about me coming from Ohio and training at Vanderbilt, doing a lot of prostate cancer. And tonight's agenda, really we're going to kind of cover an overview, but the gist of today's talk is to really discuss prostate cancer, and this is a sponsored talk from Boston Scientific and Space OAR, a product they manufacture. So we will really hone in on the radiation aspect. But in order to really understand prostate cancer and treatment options, it's going to help to understand the prostate. So we'll talk about basic anatomy, some statistics of prostate cancer, try to clear up any misconceptions. How does this get diagnosed? And then jump into treatment options, kind of give a full spectrum. So basic prostate anatomy, and this is oversimplifying everything, but it's a good representation. The prostate is part of the male reproductive system, but it does involve the urinary system as well. So here it's depicted underneath the bladder. That is accurate. So the bladder stores your urine, and when it's time to urinate, your bladder pushes urine out the urethra to the outside world. Your urethra runs right through the middle of your prostate. So if when I'm talking to a patient in clinic, I'll tell them, go ahead and make a fist, open that fist up, and that opening, that's the urethra right there. The fist itself is the prostate, and that's a pretty good analogy there. You can see that the rectum runs right behind the prostate. That's why providers and physicians will perform a rectal exam when looking for prostate cancer. And we'll talk about that a little bit more. But the rectum and prostate are very close to each other. The prostate does have zones. It has different areas, and the back side of the prostate, the side that faces the rectum, is the most likely to have cancer. And that's actually why when we put a finger in the bottom, even though that's the only part of the prostate we can feel, chances are if it's abnormal, that would be the area that we would feel an abnormality. So now that we've gone through kind of the 101 course of prostate and basic urologic anatomy, let's talk about prostate cancer. Prostate cancer is incredibly common. About 1 in 9 men will be diagnosed with it during their lifetime. And although it's incredibly common in terms of diagnosis, it's actually one of the leading causes of cancer-related deaths in American men. It's number 2 overall behind lung cancer. And that's an important stat there, that not only is it common, but there are lethal forms of it. So some 2018 statistics, they estimated it's going to be about over 160,000 new diagnoses in the US during that year, with about 29,000 deaths. Now, they add on some additional stats here that I want to review, but also clarify some things. Talk about if you're diagnosed with prostate cancer and it doesn't look like it's spread anywhere, so we call it's localized, it's not metastatic. If you get treatment for that, the chances of you living for 5 years, not dying from prostate cancer over 5 years, is over 99%. So when caught early, this is very survivable. Then they go on to describe, well, what's the 5-year survival rate for all stages combined? So now they're saying if it's metastatic, spread other places, non-metastatic, what's the 5-year survival of that, taking everyone into account? It's still about 99%. And if you take a longer timeline, what's the 10-year survival for all stages of prostate cancer? It's about 98%. Now, these statistics are accurate, but I want to paint a little bit of clarity to the picture. What this points out is that there is a very big difference in survivorship between localized prostate cancer and non-localized, meaning it's spread somewhere or it's metastatic. Localized, again, very survivable, very treatable. We don't expect you to die from prostate cancer if you get it treated. And that's much more common. Way more cases are localized. In the few cases that are metastatic, though, the actual survivorship is much lower. And so 5-year survival rates of metastatic prostate cancer are about 30%. And now that data is a little old, it's probably better than that. But the reason it looks so good on these numbers is because so many people have localized disease. The reason I think that's important to distinguish is I don't want men avoiding getting worked up or screened for prostate cancer because their takeaway is, oh, even if I get it, there's a 2% chance that I wouldn't make it to 10 years. That's not entirely true. If you catch this early, you're going to be just fine. If it's too late and it's metastatic, we can still slow it down. You have many years, but it is very different in survivorship. So I just wanted to pause a little bit there and take a little extra time to clarify these numbers. So how do we diagnose prostate cancer? And it's interesting, not all cancers that people are susceptible to get screened for. In order to screen for something, a couple things need to be true, because prostate cancer is something that we screen for. And to screen for a cancer, one, it has to be common. If it's not common, there's no reason to look for it in a lot of people. And we know prostate cancer is common, 1 in 9 men. 2, there has to be a big difference between finding it early and finding it late. This is why I explained the difference between localized and non-localized disease. If you find it early, you're going to do just fine. If we find it late, it's not quite as favorable, but we can still slow it down. So finding it early or finding it by screening is really important. Lastly, the third part of something to screen is usually whatever we're screening doesn't tend to have symptoms. So in my world in urology, I don't need to screen people for urinary tract infections or kidney stones, because patients will come in with pain with urination or back pain or blood in the urine. And so they come to me because they have a finding. Prostate cancer does not typically have symptoms. So even if you're having urinary symptoms, I'm getting up at night to pee, I have a weak stream, that is not likely to be prostate cancer. It's probably prostate to some degree, but not cancer. So prostate cancer is typically without symptoms. It is very common, and finding it early makes a big difference. So we have to screen for it. So screening, we do 2 things. One is a physical exam. That's the digital rectal exam. It's a finger exam feeling the prostate to feel for those abnormalities that could be a cancer. And 2 is a blood test called the PSA. That stands for prostate specific antigen. That's a protein that's made by the prostate. It's not a perfect test. All sorts of things that have nothing to do with cancer can cause it to be high, but so can cancer. So because of that, if it's elevated or abnormal, we need to work it up to make sure that it's not due to prostate cancer. On this slide, they do talk about non-screening detected prostate cancer, and they're talking about patients coming in with urinary symptoms. And we have diagnosed men with prostate cancer based off of symptoms. Oftentimes, though, it's coincidental. They happen to have urinary symptoms, which are very common. And in the workup, we happen to diagnose prostate cancer, which is also very common, but it doesn't mean that the two caused each other. The gold standard to actually tell if you have prostate cancer, so whether the rectal exam was abnormal or the PSA was high, we have to do a biopsy. We actually have to sample prostate tissue and have it sent to a pathologist to look at to see that it's benign or there are cancer cells in it. There's a couple ways that a biopsy can be done. On the right half, they talk about a transrectal approach. That's actually what I tend to do. It's much more common. On the left, they talk about a transperineal approach. The perineum is that space behind the scrotum but above the rectum. And it's that skin and soft tissue. There's some muscle in there reaching the way to the prostate. Now, on the right, the transrectal approach, what we do is we place an ultrasound into the bottom, just like the finger exam into the bottom, but now it's an ultrasound. And it helps us visualize the prostate, and then we can numb things up and guide a needle into the prostate to biopsy it. There's an interesting thing about the anatomy here, where if everything's positioned correctly, actually, you shouldn't feel any needle sticks or sharp or pokes. So it's actually not painful, believe it or not. There's discomfort with the ultrasound, but no overt pain. Now, on the transperineal approach, you still have an ultrasound in the bottom, but you will need additional numbing because the needle is passing through the skin and the muscle, but it's also very well tolerated. The reason people may do the transperineal approach is it per reports has a lower infection rate, because infection is certainly a potential complication, but it does tend to have higher urinary symptom issues after the biopsy. Transrectal approach, slightly higher infection rates. The reason I personally continue to do that is actually in large part a big quality improvement project of mine was developing an antibiotic protocol to avoid and lower the risk of the infection from the biopsy. So if you're one of my patients and you want to know why I don't do the transperineal, it's because it hasn't been, I haven't had the infection rates to push myself out of transrectal approach quite yet, and the patient comfort's been higher, at least in my hands. So those are the two ways to sample prostate tissue. Now, determining the severity of prostate cancer. This one can be really tricky and it can be very easy to get confused, so I'll try not to go too deep into it. But ultimately, prostate cancer, once we have the biopsy, the pathologist tells us something called the Gleason score. Now, this is, I won't go into the nitty-gritty details, but the gist of it is they numerically score the prostate cancer in terms of a numbering system to tell us how aggressive it is. And essentially, the numbers range from 6 to 10, with 6 being the least aggressive and 10 being the most aggressive. When all we have is a biopsy, though, we don't necessarily have all the information that we need to give you a final cancer stage. If we take the prostate out, then we can stage it completely because the whole thing is being evaluated. But short of that, when we have a biopsy, what we ultimately use are lots of different factors to put you in what we call risk groups. And so we use your PSA, your exam, your Gleason score, some factors about the biopsy, such as the volume of the tumor. We keep an eye on different PSA values called PSA velocity. We may send some extra testing from the tissue called genomic testing. There's all sorts of things out there. But ultimately, from the biopsy, we try to categorize you in risk scores, ranging from very low risk, intermediate, to very high. And the risk we're talking about is the risk of it being spread or metastatic. And so there's quite a spectrum here of non-aggressive to very aggressive disease that might be diagnosed on a biopsy. So when we have a diagnosis of prostate cancer, there are different ways to manage it, and a lot of different ways. So to simplify it and kind of categorize this into buckets, I like to think of it as surgery, radiation, or active surveillance. So with radiation, here on the left, they have a number of different types of radiation. And I'm not a radiation oncologist, so I'm not going to go into the nuances of all these different types. But ultimately, what they're doing is by delivering radiation to the prostate, those X-rays damage and break DNA. And when you damage and break DNA in a cell, it dies. And that's what you're trying to do to the prostate cancer. In the bottom left, we talk about surgery. There are a couple different ways to ultimately take a prostate out, but nowadays the most common is a robotic prostatectomy, removal of the prostate. Now, I do a lot of these, and this is something that I do kind of offer a lot more detailed information on in the clinics when I'm with my patients and we're talking about what treatment options are best for them. Now, radiation and surgery have different categories, or I guess different types of side effects within the same categories. And often you can have sexual side effects or urinary side effects or bowel, like GI side effects. So if you were a guy who didn't have very aggressive prostate cancer and you weren't wild about having some of the side effects, you may ask yourself, should I really even get this treated? And that's where we bring in active surveillance. So some patients will actually say, your cancer is so non-aggressive that we want to make sure it stays non-aggressive. So we're going to keep an eye on this. And only if it gets worse will we then trigger treatment options. So it's really hard for some guys, I think, to think of getting that cancer diagnosis and then saying that you're not going to treat it. But in the select population, it's actually a really good option. So because we're going to be talking more about radiation and space OAR than we will about surgery or active surveillance, let's kind of discuss a little more on radiation. So I tip my hand a little bit here on what radiation is, but it's an energy form. It's X-rays used to kill cancer cells. Now, the technology's gotten better and better, and a radiation oncologist, which is a physician who essentially is also a physicist, works on making a protocol and a program designed for you individually to minimize how much radiation the organs other than the prostate may see, because big potential side effects from radiation include urinary dysfunction and bowel dysfunction. So you may have urgency, frequency, bleeding, and this could include the urine or the stool and bowel movements. Two big kind of, again, bucket categories of radiation include external or internal. And within those groups, there are, again, you can see lots of little side options. I'm not going to go into those. I think that discussion's best suited for a radiation oncologist, but do know that an external beam radiation is much more common. And basically, it's like getting a CT scan. You are sitting in a device and X-rays are coming from the outside world towards your prostate. With internal beam radiation, something is inserted or implanted into the prostate that then emits radiation from inside the prostate outward. If anyone listening has prostate cancer and is on the fence about which radiation therapy they should go with, pros and cons, I definitely advise that you keep both your radiation oncologist and your urologist informed. Again, I'm not going to weigh in on this for this talk, but my patients have heard me express certain strong attitudes, pro or con, towards some of these interventions. And I think that should really be shared decision-making with the provider and the patient. So here there is a picture where we're looking at basically radiation dosimetry, and they're color coding it to show the severity, that basically the level of radiation is being received by an organ. So on the left here, the red center is receiving the most radiation. That's the prostate. That's appropriate. You want that to see the most radiation because that's where the cancer is. And this is in the classic, Roy G. Biv color spectrum. So that red is going to be your highest levels, and blue is going to be your lowest levels as you work further out. So you can see as you get further away from the prostate, although it's lower doses of radiation, those organs are still seeing radiation. So on the left, they're showing how much radiation the rectum itself will be seeing. On the right, they show how much radiation the bladder, the urethra, and both the penile bulb and anal sphincter will also be seeing in terms of radiation there. So although a very good and improving technology and a great treatment option for cancer, there are certainly there's some scatter effect from the radiation that's technically unavoidable to some degree, but it can be minimized. So to minimize that, here's a study that was done, and we're going to start talking about this space OAR. But here's a study that was done looking at men who received a form of radiation, or I guess a delivery style called ultra-hypofractionation. And what that is very high levels of radiation giving over only a few courses. The advantage, the patient doesn't have to come in for radiation treatments as much. The disadvantage is that in the literature, it has been shown to have increased local side effects. So this is a good study to look at, or this is a good type of radiation to look at the effects and the benefits of space OAR, because these are the patients who are really having the most side effects, because those radiation levels are so high in such a short amount of time. So when patients were, there were 551 patients basically split in half as to who got this space OAR, which again, I'll describe that in a second, but it's a gel that pushes the rectum kind of out of the way to lower the amount of radiation it sees. The men who received space OAR here had significantly fewer bowel or gastrointestinal kind of toxicities or side effects, as well as urinary, much lower urinary side effects, because this hydrogel kept the rectum and pushed the bladder to a degree out of the way of the radiation. So kind of what is space OAR and why do it? So here they have it depicted. If you remember our anatomy lesson at the very beginning, you see our prostate is and our bladder. The space OAR hydrogel is a absorbable gel that stays in place for about 3 months before it starts to absorb. And then by 6 months, it's usually all the way gone, just gets excreted into the urine. But during that time, it pushes the rectum away from the prostate by about a centimeter to reduce the amount of rectal or radiation toxicity to the rectum. Again, rectal radiation is unavoidable because it's so close to the prostate, but you can attenuate it, you can lessen it by giving it some space in there. So it's called space OAR because OAR is an acronym for organ at risk. And the organ at risk of the main radiation toxicity is the rectum. And so that's why they call it space OAR. And so when a rectum gets really bad levels of radiation, it can cause, blood in the stool, very significant bowel, urgency, frequency, pain, fistulas, which are a communication between two items that aren't supposed to communicate. And an example here would be if your urinary tract and your GI tract were connected in a place, that might be a fistula. And so you'd have kind of stool in your urine and urine in your stool. That can be very difficult to manage. And these really affect quality of life of patients. And so attenuating this risk, attenuating the radiation delivered to the organs that don't have prostate cancer is a goal of ours, of course. So the benefits of this hydrogel are that it does temporarily position the rectum out of harm's way. Again, usually by about a centimeter. So I do this procedure, although some patients may have this done in an OR under anesthesia. I actually often do this in the office, just with some medications to kind of like anxiety meds. And it takes, honestly, once the ultrasound is in place, it probably takes about 20 minutes to do all the setup, everything. And patients actually do really well with it. I believe that they always think it's going to be worse than it actually is when we're all said and done with it all. And I think I'd alluded to the fact that, again, this is absorbable, so it stays as its size for 3 months. That's enough time to have your radiation. And then over the next 3 months, so months three through 6, it gradually absorbs, dissolves, and gets passed into the urinary stream so that it's not present anymore. So the space OAR itself, it's mostly water to start, and the remainder of it is polyethylene glycol. Which if you go to the grocery store and look for Miralax, it's going to look like we've got some polyethylene glycol in there. So it's got the same stuff as some over-the-counter and prescription drugs. So it's been used a whole bunch. This is not a novel compound or a novel, something experimental or in a clinical trial. The procedure itself, again, is brief. We typically do this in the clinic. If it's in the OR, then it'll definitely be as an outpatient. But I usually do somewhere, when I'm doing these in a half day, it's usually about 5 or so in a half day. And again, this is not, I don't want someone thinking this is experimental and that you're a guinea pig. This has been looked at in tons of journal articles and reviews, and they were doing this at Vanderbilt when I was a resident, and we've been doing it out here for a while. So what we've known is in the published studies that patients who ended up with space OAR during their radiation, they're 8 times more likely to have a decline in their bowel and urinary and sexual, control patients who did not have space OAR were more likely to 8 times more likely to have a decline in their bowel, urinary, and sexual quality of life compared to the patients who had the space OAR when evaluated at 3 years out. So it helps preserve a lot of that function because those tissues didn't see the same levels of radiation as without it. So I like simple graphics. If you have more space from the space OAR, there are fewer rectal and urinary and sexual complications. And when all those are taken together, that improves the quality of life. This is a nice summary that this is, again, nothing that's experimental. It's been looked at all over the place, used all over, cancer sites in the United States. I've not had patients with, reimbursement issues. Again, Medicare and a lot of private insurers pick this up. Patient testimonial, Henry here. I think my AV isn't working great, but what I can tell you is, again, I've done a fair number of these now in the office, and I see my patients back through radiation, after radiation, and really the main story each time from the patients for the procedure is it wasn't as bad as I thought. No one's knocking down my door asking for procedures to be done to them. I understand that. They don't want another biopsy. I get all that. But it's very well tolerated, and the guys who've been coming back, I've not been having rectal bleed issues and bad urinary symptoms and bladder bleeding and all that. The guys with this have done really well. And I think we'll open it up for some questions.